I think I'll get started because it's time. Hi, everyone. I'm Dr. Judy Regensteiner, Professor of Medicine, the University of Colorado, Anschutz Medical Campus, and the Director of the Center for Women's Health Research. Welcome to Let's Talk Conversations about Women's Health, a lecture series created by the Center for Women's Health Research in partnership with UC Health, which we greatly appreciate the partnership. We're delighted to bring you this program virtually. I don't know if I'm actually delighted to bring a program virtually, but I'm delighted that we can bring you the program, and we hope to be able to meet in person again in the near future. With women often excluded from research studies, there are many unanswered questions about women's health and sex differences. The center studies women's health and sex and gender differences, particularly in the areas of cardiovascular disease, diabetes, and the intersection of mental and physical health. The center is committed to a future in which research includes women and men and accounts for sex and gender differences. We do this to shape better healthcare for all across the lifespan. We do this through research, by mentoring and training, and through educational events, such as this one. 10 years ago, Let's Talk was created to educate the community about health through evidence-based talks, each uniquely created and presented by nationally renowned experts. This evening, we will be focusing on infectious diseases. This is the center's first program on infectious diseases. We have a really fantastic speaker lineup with Doctors Michelle Barron, Andres Henao-Martinez, and Tom Campbell. Please type any questions you might have into the chat, or into the Q&A rather, not into the chat, into the Q&A. And I will be monitoring the Q&A and I'll ask questions at the end. Tonight, as you will hear, we're going to have Dr. Barron answering some questions right after her talk, but the other two speakers will answer the questions at the very end of the session. So we will want to answer all of your questions. Tonight's program is being recorded. Recordings of past events and additional resources can be found at www.cwhr.org. We will be sending out an evaluation after the talk. These are very important to us as we take your feedback very seriously. The next Let's Talk program will be in the early fall and will focus on autoimmune diseases. Our first speaker tonight is Dr. Michelle Barron. She will describe the major events in history related to infectious diseases, from the establishment of the germ theory to the concept of hand hygiene to pandemics, including the plague, smallpox, the 1918 flu, and others. Dr. Barron is professor of medicine in the Division of Infectious Diseases and is currently the medical director of infection prevention and control at UC Health. Dr. Barron's research interests are in infection prevention and control, transplant, infectious diseases, and HIV. I've been so impressed to read throughout the year, in this very difficult year of COVID, about her major role in educating and treating this pandemic, throughout our system. And she was often called upon for comment, and she was always appeared very calm throughout it, which must have been challenging at times. We would like to congratulate Dr. Barron on being named the 2021 Colorado Woman of the Year by the Business and Professional Women of Colorado. She has been instrumental in the UC Health and Colorado's response to COVID. We so appreciate her participation in this Let's Talk event. She'll be accepting this prestigious award at a virtual ceremony right after she answers questions from the audience. Dr. Barron, welcome, and thank you for being here tonight.
Thank you so much, and I really appreciate the opportunity to be here tonight. And the topic is actually a really exciting topic to me, and that I just didn't fully appreciate all the contributions that have occurred in the setting of women and infectious diseases. And so I am going to share my screen, and we will start my slideshow in just a second. If I can figure out, here we go. All right, so this is obviously going to be an abbreviated history of infectious diseases and the role of women, only in that there are so many things we could have potentially talk about, but I'm going to highlight some of the areas in which women had significant contributions, and these contributions may not have always been appreciated, but obviously were incredibly important. I put this up, and this is a cartoon that gives you just a historical timeline of pandemics. We are obviously in a pandemic right now with COVID-19, but COVID is not the first, nor unfortunately will be the last pandemic that we see. You can see that there were reports of pandemics dating back to 165, 180. So a long, long time ago. And what you're seeing in the cartoons is the magnitude of how many people were impacted by this in the setting of mortality. So the smaller the little cartoon that you see there, the less number of people were impacted by this, but by no means were they small amounts of people. Even the smallest dot, which you see here, the 1 million people from the smallpox epidemic, Japanese smallpox epidemic, that's a big amount of people. It obviously has not been updated in that this was last marked, the novel coronavirus is only having 6,400 deaths, and we're up to several million, unfortunately, at this time. I think the other thing that's interesting to note, of course, is that the Spanish flu is the pandemic that we talk about most in this time frame that we think about in terms of the pandemic of all pandemics. And I think a lot of it had to do with just historically, we had more information related to that. The one that we cannot forget that continues to exist, and I don't think people really fully appreciate that it is a pandemic because it didn't spread quickly over a year like COVID-19, but it's been occurring for many, many years, actually many decades at this point, and that's HIV/AIDS. And you can see the impact that that's had, a significant toll to society, but luckily we have a lot of successes in that realm as well. So I'm going to start with smallpox because this is something that is certainly spans the times of pandemics. It's thought to have been believed to have appeared in 10,000 BC. It causes a very characteristic rash, and it progresses from the initial initial rash to pustules, and then causes scabbing. On average, 3 out of 10 people die of the disease. If you do develop smallpox, you become immune to the disease. Inoculation, which they also use the term variolation, is basically when they take some of the material from the pustules and literally lance your skin or cut into your skin and inject it into those areas. And that was the basic form of vaccine that they had at the time. And it was, as you can imagine, not very comfortable have it done. And it came with a lot of risks as well, because they weren't necessarily completely in tune with the idea of sterile technique and didn't have the chemicals like alcohol and things that we use as a standard right now. So what about the role of women and inoculation for smallpox? Catherine the Great of Russia was actually the first person to receive inoculation against smallpox from a Scottish physician, Dr. Thomas Dimsdale. She literally had her arm sliced in several places, and pustules from a smallpox patient were then ground into her arm. There was some historical documents that suggest that Dr. Dimsdale actually had 2 horses right outside the castle waiting to take, or actually the palace, to take him away in case something bad happened to her, that he could then be out of the country as quickly as the horses could get him there. Luckily, that did not actually occur. She actually responded well to the inoculation. And because of her efforts, which were very deliberate, a mass campaign saw 20,000 Russians receive inoculations, and in over 20 years received 2 million. And you can see the quote from her that it was really her thought that this was important, and by taking the stand that she would get the vaccine first, that others would then presume it was safe, effective, and something that needed to happen. As we continue the smallpox journey, so that was in Russia, Lady Mary Wortley Montagu is also part of the British royal family, but had connections to the Russian royal family as well, and the European dynasties. She herself had become infected with smallpox, and she had been considered a very beautiful woman and had terrible scarring as a result of this. Luckily, she had lived, but knew what it could actually do. She actually introduced the concept of variolation, or the inoculation that they had been doing in Russia, into England in 1718. And it was actually something that was used pretty widely. Unfortunately, when they did this, 2 to 3% of individuals would actually develop full-blown smallpox and die. And there were other infections that you could get from this process, including tetanus and syphilis. So that was the introduction of the idea of variolation as sort of a crude way of vaccination. The true hallmark of vaccination and innovation came from Edward Jenner. So Edward Jenner is a British doctor who, when he was apprenticing with a country surgeon, noticed that the dairymaids at that time never seemed to get smallpox. And he was always, there was talk of how beautiful the dairymaids and how their skin was always going to be pure and clean and unaffected by smallpox, because they were actually exposed to cowpox. And cowpox and smallpox turned out to be similar enough that the cowpox actually gave their immune systems a boost and protected them from actually developing smallpox. So he decided to do some investigations and found, if you do the same idea of variolation or inoculation of the material, but this time, instead of using the smallpox virus or the material from smallpox lesions, he used cowpox instead. He was able to show that it protected against smallpox, and he developed the first vaccine for this. We are very fortunate in that this vaccination has been proven to be effective. And on May 8th, 1980, the World Health Organization declared the world smallpox free. The only place you still see smallpox is in research labs where there's investigations. And if there were to be a smallpox case, it would be considered an act of bioterrorism. Puerperal fever was something that was very common in the 18th century, and was associated with women who had given birth or who had had miscarriages. And there was a lot of sort of mystery around this in terms of what it was thought was causing this. It was obviously thought to be something associated specifically with women, and thought perhaps because it was associated with childbirth, that there was something bad in the air. There was a common theory called miasma that explained why women of childbearing age seemed to succumb to this type of infection. Ignaz Semmelweis was a Hungarian doctor born in the 1800s who worked on an OB ward in Vienna Hospital. And it was there that he recognized that this incidence of puerperal fever didn't seem to occur in the same fashion. He noted that if the OB ward had doctors or medical students working on it, that it was 3 times more likely that these individuals were going to die or have mortality compared to those that were attended by midwives. And so he really started to question. He's also not only the forefather of infection prevention, but also an epidemiologist in terms of trying to understand what were the differences. So he started looking and doing investigations, looking to see, did they get different food? Did they have different linens? Were they treated, delivered in a different fashion? What finally actually sort of helped him understand what was really potentially going on is when one of his male physician colleagues died. And on autopsy, when they looked at the autopsy findings, he had the same findings as the women who had been dying of puerperal fever. So he finally came up with the idea that maybe this was not a female issue, but perhaps there was something unique to what was actually transpiring, and perhaps this was being transmitted through his hands. One of the things he noted was that the medical students and the doctors often would perform autopsies and then go deliver the babies or care for the women that were having miscarriages. Midwives did not perform autopsies. So he something that was coming from the dead bodies that was then potentially contributing to the infection that then subsequently occurred after giving birth. So in order to experiment and figure this out, he came up with the first way of washing your hands appropriately. He instructed all his staff and the students that they had to actually clean their hands with a chlorine solution and also clean their instruments. In the time frame over 6 months in which that occurred, he had a fourfold decrease in OB mortality. Unfortunately, like a lot of innovators, he was not appreciated for his efforts. And over time, this practice fell off and people found it inconvenient and decided they didn't want to do it anymore. And he actually lost his job. Routine antisepsis in OB was not introduced for over 20 years later. And unfortunately, you can imagine the lives that would have been saved if individuals had just actually followed through with this. And obviously, this is the basis for infection prevention, that hand hygiene is the basic thing that we can do that's simple, effective, and saves lives. Yellow fever is something that on that initial slide I showed you is a cause of significant pandemics and still is in existence today. It is spread through mosquito bites. It's thought to cause at least 200,000 cases per year with a significant number of deaths, with most of those occurring in Africa. On the map that you can see in the yellow are the areas that are affected by yellow fever in Africa as well in South America. People that develop this will develop initial flu-like symptoms, fever, chills, body aches. About 15% of these individuals will actually develop serious disease and can die from this complications. And so it is not without its consequence. Clara Louise Mass was an American-born nurse who was born in the late 1800s. And soon after acquiring her degree, she joined the Army as a contract nurse. She worked in the Spanish-American War. She also went to the Philippines. And a lot of her work was taking care of soldiers that were dying from the infectious diseases of the time: smallpox, yellow fever, typhoid. She then moved to Cuba and was working again with the government as a nurse caring for individuals, and they were doing yellow fever research. She volunteered to be part of the experiments and allowed herself to be bitten by mosquitoes that had been feasting on individuals with yellow fever. In June of 1901, when this happened, she did okay, and she had a very mild infection, and it was thought that that would be enough to give her immunity, and she agreed as part of this experiment to get bitten again, with the idea that she was probably immune. Unfortunately, she was not immune. She actually got severely ill and she died. She was only 25 years old. No further experiments were conducted because of the news of the death of this young woman and for all the work she had been doing as a nurse. Unfortunately, again, she was never able to see potential beyond this. You can see that there was a postage stamp that commemorates her life. And the fact that she was so dedicated to this, the reason she volunteered was because of what she had seen and the devastation it had caused, and wanted to ensure that others someday would not be facing the same challenges. It wasn't until 1937 that Max Tieler, a South African American, developed a yellow fever vaccine that was considered effective, and he received the Nobel Prize for this in 1951. Susan LaFlèche-Picotte, Dr. Susan LaFlèche-Picotte, was born on the Omaha Reservation in Nebraska in the late 1800s. She is the first Native American to receive a medical degree in the United States, and she received this from the Women's Medical College of Pennsylvania. She did a lot of work in sort of the realm of public health that had implications for infectious disease transmission when she returned to her reservation after completing her studies. She insisted on proper hand hygiene, not having communal drinking cups at ceremonies because she knew they could potentially transmit infections, advocated for screens on doors to keep out flies and mosquitoes, tried to ban liquor sales. She accomplished a significant amount, especially for a person of the time where she was not considered someone that would have ever been considered to go to medical school. Before she died in 1915, she actually managed to raise enough funding to be able to have a modern hospital built on her reservation, which was a huge accomplishment. Leprosy, or Hansen's disease, is caused by a bacteria called Mycobacterium leprae. It takes up to 20 years to develop signs and symptoms of the infection, and it's a horrifying disease. It affects the nerves, the skin, the lining of the nose. It can cause people to lose sensation. They often lose their sense of, with that loss of sense of touch, they're more susceptible to injuries. You can see the spectrum of disease that this can occur. And at one point, all these individuals were put in leper colonies because of the concern about spread, but also because they just had such acute deformities and needs that they weren't considered able to live in society. Alice Augustus Ball, was born in 1892 in Seattle, Washington, and she was the first African American and first woman to graduate with a master's degree in chemistry from the College of Hawaii, that is now the University of Hawaii. She was doing research on leprosy treatments and had learned from local healers that there was an oil from the chalamuga tree that existed that seemed to have some benefit. Unfortunately, when you extracted it directly from the tree and tried to inject it, it caused abscesses and caused all sorts of complications. And actually, while it maybe helped, it really didn't seem to help significantly. Using her chemistry degree, she was able to isolate the components, figure out what actually was the part that would potentially be beneficial, and was figured out a way to emulsify it so that it could then be injected into these lesions. This actually later became known as the Ball method and was the treatment of choice for thousands of individuals afflicted with this until antibiotics came into fashion that were able to treat this. Unfortunately, she died at the age of 24 in a lab accident. And even more unfortunate at the time is that she had not published all her findings, and she didn't actually get credit. In fact, not only did she not get credit, but her mentor and the president of the university actually published her data without giving her recognition. Luckily, she had a surgeon colleague who had been working with her, who many years later published a paper and explained her role in this methodology and ensured that she got credit, but she vastly remained unknown until the 2000s. She now has a scholarship that's in her name at the University of Hawaii, and she has received recognition from the Leprosy Foundation with a plaque on their building, and also a plaque in Hawaii on one of the trees in which she extracted this chemical from. Tetanus, we all know about our tetanus shots and botulism. Anybody that's done canning knows about botulism and thinks about that as a concern. They're both caused by bacterium in the Clostridium species. They're often found in soil and they can develop spores. In both instances, both the diseases are horrifying. Tetanus can cause lockjaw, but it really causes these horrible spasms and can actually cause bone breaks because of the amount of spasms from this. Clostridium botulinum botulism has different modes of transmission, but that too also can cause paralysis. Both can be deadly. Tetanus is treated with antibiotics, antitoxin, and vaccination. For botulinum, there's an antitoxin and medical support that's required. A lot of the work that we have and the treatments we have available have to do with this woman, Ida Bengtson, Dr. Ida Bengtson. She was born to Swedish immigrants in Nebraska. She became the first female PhD to work at the Public Health Service's Hygienic Laboratory, which is now the National Institutes of Health. She did a lot of epidemiological work and actually found an outbreak of tetanus related to smallpox vaccine practices. She also was the one that discovered that the infantile paralysis botulism was caused by this bacteria. She also developed a typhus vaccine, developed lots of laboratory studies that we use for tick-borne diseases that are still used today, and her accomplishments are immeasurable. Brucellosis is a zoonotic infection due to Brucella species. It also affects animals, and that's where the zoonotic component comes from. It's been found to be associated with unpasteurized rare dairy products, and also can be inhaled when you work amongst a slaughter of animals. Can also get through skin and wounds. It can cause fever for long periods of time. It's something that is on the list of infectious diseases that we think about when we're working up fevers of unclear etiology. And the best way to prevent this is adequate pasteurization. Alice Evans is a bacteriologist who received a scholarship and got her master's degree, first woman to do this at the University of Madison, Wisconsin. She's the first scientist to be a bacteriologist as a permanent position at the USDA. And she determined the relationship between brucellosis and unpasteurized milk. Again, like a lot of the people of the time, her work was met with lots of skepticism, especially because she was a female and because she was not a PhD. It wasn't until scientists in Europe published their data that they finally realized that her work was not only accurate, but important. And we pasteurize milk and dairy products because of her efforts, and it probably saved a significant number of individuals from becoming ill from both brucella and other illnesses. Rubella, or German Measles, is a virus that for a long time caused horrible congenital defects in women that were pregnant. It was something that we did see in the United States, and had the last epidemic of rubella was in the 1960s. You can see the impact it had on both miscarriages as well as newborn deaths, and the impact on congenital disease. This is a vaccination that we routinely receive as part of our MMR, R being the rubella, and there have been no major outbreaks of rubella in the United States since 2004. This has to do with the work of Hope Hopps. She again was received a bacteriology degree and then continued her work and got a master's. She was the one that developed the cell lines that were able to be used for them to be able to develop the vaccines. The two people pictured here with her in the middle are Doctors Harry Meyer and Paul Parkman. It's interesting in that this photo, when it was first put out in the archives, she is mentioned not by name, but as simply as a laboratory technician. Clearly, her role and significance was not noted in this photograph. However, she was included in all the publications. She also received 2 US patents for her discoveries. Last but not least, bringing us to the current era where we are with COVID-19 vaccines, there have been many women that have had significant contributions to this. Catherine Jackson, Dr. Catherine Jackson, is actually the head of the Pfizer biotech lab that developed the Pfizer vaccination. Catalin Carrico, Dr. Carrico, is the individual whose work on mRNA research is the foundation for the Pfizer vaccine, as well as the Moderna. Interesting enough, Dr. Carrico was a professor and was actually demoted because she could not receive funding for her mRNA technology that she had been working on. And nobody actually believed that it would be something that was worth investing in. And of course, we know the rest is history. Dr. Kezmezia Corbett is a PhD who worked at the NIH on the Moderna vaccine, and she was in very important part of her work was developing the proteins that go into the vaccine that stimulate the immunological response. And last but not least, Dr. Lisa Jackson led the first clinical trial with the COVID vaccines, and started with Moderna and also helped with the Pfizer vaccines. And so again, their contributions are immeasurable. So with that, I leave you with this, a quote that I enjoyed reading and think about, and especially in light of all the contributions that these women have made, I encourage people to go into the lab and to support their work. And I will stop there. Thank you.
Thank you so much, Dr. Barron. That was great. I had no idea that the major role of women in general, as well as women of color in these developments. It's very impressive. So it's great to see. Of these diseases, do any of the ones that you described tonight remain a threat, the historical epidemics that we have witnessed?
Yeah, so yellow fever, Dr. Henao-Martinez will probably talk a little bit about yellow fever and travel. And that's certainly something that continues to plague us. I think so many of these diseases don't exist because of these contributions, because we have vaccines that work and we have trust in those vaccines and we take it for granted. I mean, I don't even think about like MMR, measles, mumps, rubella. We do not see that in the United States. Why? Because we have a highly vaccinated population. They do exist outside of the United States. And I think that's something, again, we take for granted, that we don't get tetanus, that we don't have rubella, that we don't have a lot of these diseases that was based on these individuals' work. And other countries don't have that luxury, unfortunately.
I have a question for you from an attendee asking how many years of work went into the COVID vaccines?
The mRNA work that Dr. I'm gonna mess up her name, but yes, she did years and years and years of work. She was so invested in this technology and believed strongly that it had potential for oncology applications, for vaccine applications. And again, it was dismissed. They wouldn't fund her. And so she was demoted from her position. And I think that just tells you sometimes people that are most innovative and are most likely to have something that impacts the world may be dismissed as crazy. And we see that in science throughout history, of people that were later lauded as geniuses were not necessarily seen that way at the time. But I think her research was like 10, 15 years worth of really amazing research that was basically ignored.
I just heard her name for the first time about a couple weeks ago. So that's too bad, but it's really impressive. And there are a lot of infectious diseases. Is something else that I took from your talk, and it's good that we have people to combat them. I have another 2 questions, and then I'll let you go. Is that okay?
Yes, absolutely.
I've heard, this question reads, I've heard that the technology around the COVID vaccines is different than more traditional vaccines. Can you talk about that? Also, why is the cold storage so critical? And I know Dr. Campbell will be talking about the vaccines as well. So.
Yeah, and so I probably don't want to steal his thunder or his expertise, because I think Dr. Campbell will be speaking to some extent about this. So I'm actually going to allow that question to be deferred till the end of his talk. And I think he'll be going through some of this. And I can answer the cold storage part because that's the easier part. mRNA is something that is very fragile, and Tom will probably potentially talk a little bit more about this, but the temperature, maintaining it at that temperature keeps it from degrading. And it's if you've ever worked in the lab with mRNA, you have to be very meticulous in how you do things, because any introduction of chemicals or other things can completely keep your project from working, because it just degrades so quickly. DNA is actually easier to work with than RNA. RNA is a lot more delicate.
And the other 2 questions are more about vaccines, but one more question. Do you feel that future childhood vaccines will be made via the mRNA process?
That's an intriguing question, and I think that's a great question to ask, especially given what we've seen in terms of their efficacy. And I think that's something we will obviously be looking at to see if there's more constructs that are used in that fashion. Maybe a better flu shot in the future will be using mRNA vaccines. I think that now that this technology has been proven to be safe and they know how to manage it, I think we're only going to keep moving forward in terms of how we work with those things. There may be some that we already have good vaccines and they're simple, like tetanus. Do you need to reinvent tetanus? Probably not. You get it every 10 years, but certainly other diseases that are like flu and some of these other viruses that we're allowed in the future, this might be a great technology to use.
Thank you so much, Dr. Barron. Congratulations on your award.
Thank you very much. My pleasure.
Thank you. Our next speaker is Dr. Andres Henao-Martinez. There he is. Okay. Dr. Henao-Martinez, thank you so much for coming tonight. Dr. Henao-Martinez is the director of the travel clinic at UC Health, University of Colorado Hospital, and has been since 2016. He directs the outpatient infectious diseases rotation for the internal medicine and preventive medicine residency programs at the University of Colorado School of Medicine. His research interest is the study of host susceptibility factors to different fungal and tropical infections, including Chagas disease and Cryptococcus. Over the next year, this is a fascinating topic, it really is. As more people are vaccinated and begin traveling, as travel restrictions will ease, we're going to see more and more travel. Several factors can place a traveler at risk for some infections or exposures. Dr. Henao-Martinez will discuss the main travel-related illnesses and some effective preventive measures that can be taken before travel. But hopefully he will also say that we can travel safely, or we will be able to travel safely. Thank you, Dr. Henao-Martinez.
You were welcome. Thank you for having me.
Our pleasure.
All right. Yes. I want to briefly kind of introduce what is the most common thing that we see in people who are traveling, what are the most potential risks, and how we can put in place some measures to keep us healthy when we're traveling. So I don't have any conflicts or disclosures for this talk. And basically want to quickly going through the different factors placing travelers at risk, kind of overview one of the most common infectious diseases affecting travelers, and discuss tools and measures that can, prevent the acquisition of those infections. So international travel, and this applies obviously most for international travel. Before COVID, obviously, was very, very common. In 2010, this is figures, that have been growing until the pandemic started, but about 60 million trips were taken outside the US when at least one night is spent. And reason for people to travel, everybody think about pleasure and having fun, but there is a number of other reasons why people travel. It might have to do with their jobs. It might be people going back to their home countries to visit friends and family, people trying to adopt a child. So there is other reasons which can modulate the time you spend, the country you visit, and the risk you're taking that can put you risk for infections. So we live in an interconnected world, and before COVID, you think about a specific country, and sometimes as an infectious disease specialist, you also kind of focus on what potential infections may occur in a particular country. But in this world that is very interconnected, we have very global connections. You can actually acquire anything around the globe, and because of travel, you ended up managing that infection in some other places. So travel medicine is a specialty in itself, and a lot of us as an infectious disease specialist kind of provide a little bit of our expertise. It's very common, unfortunately, for travelers to get sick. Unfortunately, most of the common infections that they get are really self-limited and mild. But as you can think about it, between a quarter or half of the travelers may develop some sickness, and many of you maybe have developed some disease while they're traveling. And as you can see, the most common thing that the travelers acquire are diarrhea and sometimes respiratory infection or skin infections. Around 4 million people can get ill enough that they need to seek care when they are traveling. So it's something very important, and a lot of people kind of dedicate time to monitor this and prevent these infections from happening. It's important to know, though, that when you are traveling internationally and in the era of COVID-19, you always worry about potential infectious diseases and other exposures. But it's also important to keep in mind that a lot of complications had to do with non-infectious problems like trauma and motor vehicle accidents, or people who are already sick and they develop like an exacerbation, a flare-up for their own disease when they're abroad. And so just to keep it in context, is more likely to die from an injury while traveling than from an infectious diseases. So it's important to keep some safety precautions also in mind. And so you can see, if you're traveling, this is kind of, again, trauma and violence might be something that we might experience more commonly. So that's something to keep in mind also when we're arranging our international travels. So we live in a world now that we're having emerging infectious diseases, and as we have seen with COVID, it really changed, you know, a lot of the economy and really changed the way we live. In average, it's anticipated that we are going to face one emerging infectious disease at least a year. And so we have seen this, a number of different infectious diseases over the last decade that affected us with some degree. So it's always important to keep in mind that, you know, it's always a threat that a new infection might be coming up to affect, you know, the planet. This is kind of COVID-19, kind of the latest state from the New York Times, as we see is an evolving epidemic. And it's important to keep in mind when we're traveling, you know, because when we're going abroad, we'll have to keep in mind how is the status of the COVID-19 pandemic in a particular country, what measures they have for controlling the epidemic, which can affect us that we're traveling, and if sometimes they do require some testing for us before arriving to the country. So we know that this was updated from the CDC just recently for domestic travel. It's important to know that, you know, for fully vaccinated people, we only need to self-monitor symptoms and wear a mask and other precautions during travel. But if you haven't been vaccinated, it's important to get tested, you know, after travel or self-quarantine to prevent, you know, a spread of a potential infection. For international travel, is really, really changes and the regulation and depends on each country. But it's important to know that as of right now, United States is requesting a negative COVID test before you can re-enter the country. So if you are going abroad internationally, that country you are arriving might request a testing as well. But when you come back to the United States, you really need to have a negative test. And if it's positive, the recommendation is for you to travel, to immediate isolate and follow the public health recommendations. So something to keep in mind when we are arranging an international travel. The way we monitor infectious diseases, we use different network and surveillance in which we can, you know, help us decide, you know, what is being present among travelers. These numbers are kind of maintaining a little bit, especially before COVID. Still, travelers' diarrhea is a very common infection, but keep in mind that malaria is an infection that we see commonly. And we do have measures for us to prevent malaria from happening. Then you follow by respiratory viruses and also viruses that are transmitted by mosquito bites like dengue or Zika or chikungunya. So it's important to recognize for us, and I want to give you the perspective from the specialists in the travel medicine, is that, you know, depending on where you're going is what is going to modulate your risk. And just to give you an example, if you're going to sub-Saharan Africa, then your risk to acquire malaria goes up because that's where, you know, a lot of the endemicity for malaria is. Versus if you're going to other places, then you might more likely to acquire other diarrhea illness or respiratory illness. So the geography really plays a role here in terms of how we assess your particular risk for acquiring an infectious disease as well abroad. So a lot of factors modulate how you acquire particular infectious diseases, and it has to do with, we've been talking about geography, what countries you're going to visit, how long you're going to be in that country, what type of activity you're going to be doing in that country. Are you going to spend time indoors or outdoors? Are you going to be close to potential vectors like mosquitoes or flies? What type of food are you eating? What type of accommodations? So all those things can modulate how you can acquire a particular infectious disease. And something that we do in travel clinics is kind of know more a little bit about your travel, know more a little bit about your accommodation, and trying to give you a little bit of recommendation for you to, you know, have safety measures to have, you know, healthy food, healthy beverages, how to stay away from mosquito bites. And we also modulate, you know, your own risk. I mean, are you healthy? How you have your vaccinations? do you have a medical problem already? Do you take medications on a daily basis? That can also tell us a little bit more about potential risk for complications. It's important to know that, women travelers are generally younger, have a shorter duration of travel. They like to travel for pleasure most of the time. And as expected, they seek advice before traveling, and they kind of take measures to prevent any illness. A little bit indifferent with men, they tend to develop diarrhea and respiratory infections a little bit more commonly, as opposed to sexually transmitted infections. And urinary tract infections, unfortunately, a little bit more common in women, and also other adverse reaction to medications and dental conditions. So a little bit of a quick overview of malaria. Like I said earlier, traveling to sub-Saharan Africa, becomes one of the major risk factors. We see about 1,500 cases every year here in the US of people traveling to endemic areas of malaria. So it's important to consider. And we see the map and evaluate, where malaria is and where you're going. And what activities you're doing. The mosquito that transmits malaria only bites in the evening and nighttime. So sometimes we see travelers, going on cruises and boats, so they're going to spend the night on the boat indoors with air conditioning. So the risk is going to be low compared to somebody who's, camping or hiking, where, you can have an increase for mosquito bites. Zika virus is another infection that, really affected travel back in 2015 and affected pregnant women. Was an outbreak that was initially documented in prior years in the Yap Islands, and then the French Polynesia, and then arrived to the Americas. We had a lot of reported cases in the US and the US territories. And it was important to know that, if affected, childbearing woman or pregnant woman, because it can, lead to congenital defects. Fortunately enough, despite the peak of the 2016, the activity of Zika virus has decreased substantially. So over the last years, the surveillance hasn't detected a lot of ongoing transmission. This is still possible, but fortunately enough, the risk has become very, very low. There's still recommendations, in countries like they highlighted there in the map, especially in Central and South America. It still might have a little bit of risk because they can have a little bit of low transmission of the virus in some endemic areas. So it's important to kind of discuss that with your provider before you're traveling and see what measures you can take. Like I said, the risk overall, unfortunately, is very low now, but it's not zero. So there's important preconception counseling recommendation that we do for women that want to get pregnant or they are already pregnant and they are traveling to those areas. And we follow kind of CDC recommendations in that regard. But, mosquitoes not only transmit malaria and Zika, they can transmit these other viruses, chikungunya, dengue, yellow fever, and Japanese encephalitis. It's important to mention, as Dr. Barron was mentioning, we do have a vaccine for yellow fever. And there is some countries where we know there is endemicity for yellow fever. And some countries in Africa, especially, they want to request a certificate that you did receive the vaccine. And normally it's given only in specialized clinics and travel clinics. We also have a vaccine for Japanese encephalitis that is more pertinent for traveling to the Southeast Asia, but we can really modulate and decide if that's something that a traveler should get. Traveler's diarrhea, I want to briefly touch base on that because it's very common, and probably any of us have experienced this while traveling at least once. And, bacteria is very common to have. There is some risk factors depending on where you're going. So in red, for instance, in the map, your risk for traveler's diarrhea is higher. And if you're younger, you probably are more inclined to take a little bit more rest when you're food, and that might put you increased risk for some diarrhea. and there is some season also that might play a role. There is some prevention that we can do to manage what we eat and what we drink, what we're drinking. And there is some vaccine that are transmitted through food, like hepatitis A, typhoid, and cholera, that we can decide if you're a candidate for those vaccines, or what other measures we can do to kind of help you in case that happen when you're traveling. The CDC has very nice an app that you can download. It's called Can I Eat This? And kind of help you, depending on you're going, depending on your type of food, can help you, guide you to see what food might be safer for you when you're abroad. The skin lesions are also common. This is a leishmania, a parasitic infection that is transmitted by the bite of a fly. And sometimes we see it in travelers, especially those that are going to more cell-bite regions and they are more exposed to the bites of those flies. Sometimes because people are not very common with this type of infection, they get a delayed diagnosis. So we also offer a little bit more of that specialty in our clinic. Skin infections can be a different way they can present, but they're very common among travelers. So you see a parasitic infection there on the top pictures, and kind of a allergic reaction on the bottom. But you can have all kind of different ways in which the different infection can manifest through the skin. And so you have this very exotic, sometimes infection that we get to see in our clinics in travelers that might acquire those infections in other countries. Tuberculosis is important to know, especially for healthcare workers. Is very still one of the major killers in the world in terms of infectious diseases. And I just wanted to mention, to finalize, when I provide, this is where we work. We specialize in giving preventive measures for people that are traveling, especially internationally, and also manage people that are getting sick when they're abroad. And with that, I want to kind of overview the measures that you can do to prevent yourself from getting sick. And keep in context, when you are traveling with family and you're pregnant.
Thank you very much, Dr. Henao-Martinez. I really appreciate it. We're going to take questions after Dr. Campbell's talk, and we'll go right into his talk. And please write your questions in the Q&A section. We have a few good questions, and we'll bring back the hand washing and vaccine questions for after Dr. Campbell's talk. So Dr. Thomas Campbell is Associate Dean for Clinical Research and Professor of Medicine and Microbiology at the University of Colorado School of Medicine. He's a Chief Clinical Research Officer for UC Health as well. He treats clinical infectious diseases at UC Health University of Colorado Hospital, and he serves as the Principal Investigator of the Colorado AIDS Clinical Trials Unit. His research focuses on the evaluation of medicine to treat viral diseases such as HIV, AIDS, and COVID-19. And he has been called into action this year for sure, heading up some of our vaccine trials. So he's immediate source for a lot of information about this. He's going to review the most up-to-date data on the safety and efficacy of vaccines to prevent COVID-19 tonight. He will compare the safety and efficacy of the COVID-19 vaccines that have received emergency use authorization, which is all of them. They're all under emergency use authorization in the United States, including their efficacy in women. Thank you, Dr. Campbell.
Thanks very much, Judy. It's a pleasure to be here this evening to speak to everyone. So before we start talking about COVID vaccines, I want to talk in more general terms about human coronavirus infection. Human coronavirus infection. So the cause of COVID-19 is a coronavirus that we call SARS-CoV-2. And it's one of 3 coronaviruses that have caused recent epidemics in humans. Others include SARS-CoV, and MERS-CoV. SARS-CoV and MERS-CoV never reached pandemic proportions, and those epidemics were easier to control by public health means. But these three epidemic coronaviruses are part of a larger family of coronaviruses. And there's at least 4 other coronaviruses that routinely infect humans. We call these endemic human coronaviruses. And these have been with us for thousands of years or more. And I've shown in this diagram here on the right, I've blocked in red the 4 endemic coronaviruses. And you can see that if you follow the distance along these lines, although some of these coronaviruses are closely related to each other, and SARS-CoV and SARS-CoV-2 are closely related, there's a lot of genetic distance between most of these viruses. And what that means is that these 4 endemic coronaviruses that we're all exposed to, all humans get infected with all 4 of these at some point in our lives, and most of us get infected more than once. But the distance is so great with SARS-CoV-2 that we don't expect that having had any of these 4 viruses provides any protection against SARS-CoV-2. But we do know some things about these endemic coronaviruses that perhaps can inform what we can expect with immunity to SARS-CoV-2. And there were actually experiments in this. I've taken this information from a paper that was published over 30 years ago in 1990, where 15 healthy human volunteers were intentionally infected with the 22.9E human coronavirus. So they were intranasally inoculated with it. And only 10 out of the 15 actually developed detectable infection. And of those 10 infections, 8 of them were associated with fairly mild cold symptoms. So these are viruses that are a cause of the common cold. What's important, though, is that those who did get infected had lower baseline antibody levels to this coronavirus. And then after getting infected, antibody levels rose, but then declined over the subsequent year. And then a year later, 14 of the original 15 were infected a second time with the same coronavirus. This time, 11 out of the 14 developed a measurable infection, but the symptoms of the common cold only occurred in 1 out of those 11. So the symptomatic infection was much less common. Also, the duration during which the infected individuals shed virus was shorter the second time. So the first time they shed virus for a mean of 5.6 days versus 2.0 days during the second infection. So I think this informs what we can expect both from naturally acquired immunity to SARS-CoV-2, as well as perhaps from a vaccine. And the conclusions I draw from this are that recovery from natural infection provides only partial protection against subsequent infection. And mainly the protection that it provides are decreased symptoms and decreased duration of viral shedding. The protection from this natural infection wanes with time. And importantly, the measurement of antibody levels may be a correlate of that protection. So I think we can then sort of create a paradigm of what an impactful COVID-19 vaccine would look like. So I use the term COVID-19 to refer to the illness that's caused by SARS-CoV-2. And what we'd expect is that after 1 or 2 doses of a vaccine, over time, there would be an immune response, and this could be measured as in the previous experiment by antibody levels. That's not the only measure of immune responses. And with time, this may wane, but there would be a memory component to the immune response such that if there was exposure to SARS-CoV-2, in the future that memory response could kick in and provide protection. Now, that protection may or may not prevent infection, and that's not necessarily the goal of COVID vaccines. But what would be important is to prevent disease, prevent hospitalization, prevent death, and hopefully also prevent transmission to others. So as Judy mentioned, there are some vaccines in the United States. And I've just outlined here what the worldwide pipeline looks like. Worldwide, at the start of all this vaccine work, there were 250 candidate vaccines. 69 of those have been evaluated in clinical trials in humans. Here in the United States, there are only 6 vaccines that have been evaluated in phase 3 clinical trials. So those are the last stage of clinical trials where large numbers of people are enrolled to determine efficacy. And I've listed those 6 here, and they include the Pfizer and Moderna vaccines, which are messenger RNA-based vaccines. The Johnson & Johnson, the AstraZeneca vaccines are adenovirus, and Novavax and Sanofi are protein subunit. So there was a question asked of Dr. Barron earlier about the differences in these technologies. And basically, these RNA vaccines provide the genetic information for the coronavirus protein in the form of an RNA. The adenovirus vaccines provide that in the form of DNA that's packaged in a shell of an adenovirus. And the protein subunit vaccines are an older technology that have been around for quite some time, for 30 years or more. And those are more traditional approach. Now, the RNA vaccines received emergency use authorization from the FDA in mid-December. The AstraZeneca vaccine at the end of February. AstraZeneca should be filing for EUA in the US pretty soon. It is approved in Europe. The protein-based vaccines are not there yet. Novavax has completed enrollment in their trial, but has not reached the point of filing for an EUA yet. Sanofi had to delay the start of their trial to next month because of difficulty in producing the protein subunit. So kind of an answer to the question that was answered earlier, if we were reliant on this technology, the protein technology for creating these COVID vaccines, right now, we would still not have a effective vaccine to use. And it was the RNA technology and the DNA adenovirus-based technology that allowed us to proceed so rapidly to get safe and effective vaccines. So what these vaccines all have in common, the RNA, the adenovirus, and the protein, is that they all target a specific part of the coronavirus, and that's called the spike protein. And you can see from this cartoon why it's called the spike protein, because it radiates like spikes out of the surface of the virus. And from work that had been done in other coronaviruses, both human and animal, we knew that the spike protein was likely to be the best candidate for a vaccine. Now, the spike protein doesn't really look like this. Based on X-ray crystallography, it looks like this. And what's important about the spike protein is that the active part that enables the virus to infect cells is called the receptor binding domain. And we've recently seen the emergence of variants that have mutations in this receptor binding domain. And these variants have arisen in different parts of the world. Of course, the ancestral strain of SARS-CoV-2 originated in Wuhan, China, and then spread to Europe, and then eventually to the US and the rest of the world. But there have been variants originating from this that have taken place, or initially detected, I should say, in England, called B117, South Africa, B1351, Brazil, P1, and actually one homegrown here in the US originated in California, and that's the B1427 and B1429. These are important, these four are important because they all have mutations in this important receptor binding domain. And that affects the efficacy, or we think it affects the efficacy of the vaccines. It certainly affects the potency of the antibodies that are induced by the vaccines. Of course, the goal, as I mentioned, of these vaccines is to induce an antibody response. And so what you see here is this D614G, that's the ancestral Wuhan strain. And that's the genetic sequence that's used to make all 6 of the vaccines that I've just mentioned. And so the vaccines produce very high levels of what we call neutralizing antibody against this particular strain. But when you compare that to other strains, such as B117, you see a slight, in this case, not significant reduction. But with these other variants, including the B1351, where there's a 6-fold reduction, the P1 a 3.5-fold reduction, and the B1427 and 429 2.8-fold reduction, we see decreases in the potency of the antibodies that the vaccines produce. Notice it's a decrease and it's not a total obliteration of the potency. So there is still, we expect, some protection. And these variants have spread through the US. This is the most recent data from just this afternoon. And you can see over time, the colors at the bottom of these bars represent the 4 variants that I've mentioned. And they've spread such that as of the middle of April, across the United States, 83% of all new infections were caused by one of those 4 receptor binding domain variants. And this shows the state by state data. And here in Colorado now, 73% of all new infections are due to these receptor binding domain variants. And I should mention that it's not just that they affect the potential efficacy of the vaccines, but they are also more infectious and they can be spread much easier than the original strain. So in terms of thinking about how we measure the efficacy of a vaccine, again, there are different things that we could measure. We could measure prevention of infection, prevention of disease, prevention of hospitalization, prevention of ICU admission, prevention of death, and prevention of transmission. All of those things are important, and we actually measure them all. Although for the COVID vaccines, it was the prevention of disease that was the main efficacy endpoint. And when we measure vaccine efficacy, what we're measuring is the proportional reduction in the ability of the vaccine to prevent disease in the vaccine group compared to the control group in which received placebo. And just to give you an idea of what we would expect, these are the what we know about efficacy for vaccines for other viral diseases that we use very commonly and have used very commonly for many years, including hepatitis A virus, hepatitis B virus, and the flu virus. And you can see that vaccines that are in the 70 to 80% or greater range are things that work very well. So vaccine efficacy, as I've described here, is what's measured in clinical trials. What's also important is vaccine effectiveness, and this is what's measured in the real world on population levels as vaccines are beginning to be put into use. And I'll mention more about this in a few slides. So how does vaccine efficacy compare across these vaccines? So I mentioned that symptomatic infection was going to be the main measure that these vaccines intended to have an effect on. And you can see that all 6, well, actually, there's only 5. There's 5 here because we don't have data on Sanofi yet. But for the 5 that we do have data, we have really great efficacy for preventing symptomatic infection in the 70 to 90% range. Asymptomatic infection, or preventing any infection at all, we have much less data in a bit of a range, in probably somewhat not quite as effective for some vaccines. For preventing severe or critical illness, so this would include hospitalization and ICU admissions, these vaccines are very efficacious, in the order of 70 to 100%. Now, in terms of variants, I mentioned the UK B117 variant. Vaccine efficacy is maybe a little bit less, but it's still very good in the 70 to 85% range. For the South African variant, it varies by vaccine. The Pfizer vaccine still has very strong efficacy against the South African variant, 100%. Johnson & Johnson and Novavax are in the 60% range. The AstraZeneca vaccine, though, is not very effective against the South African variant, only 10% if it's even a positive number. So it's also important to know how vaccine efficacy varies in special populations. And so these trials, when they took place, took special care to enroll significant proportions of people who were older, who were African American, Hispanic, and women. So, relevant to the topic of this conference, roughly 45 to 50% of the participants across these trials were women, 20 to 30% were Hispanic, and right around 10% for these trials was African American. And so you can see as we look across these populations that vaccine efficacy does not vary by age, by race, by ethnicity, or by sex. So a very similar vaccine efficacy in these categories. An important important special population is children, and unfortunately, we don't yet have any data on vaccine efficacy in children. Those trials are just getting started. And I mentioned the concept of measuring vaccine effectiveness in real world settings, and we're starting to see some data emerge from that. And you can see that for symptomatic infection, the Pfizer vaccine, for symptomatic, for any infection at all, for preventing hospitalization, severe infection, and infection in older individuals is very, very good and is on the same order of what was measured in the clinical trials. There are data for Moderna that looks very much the same as Pfizer, but the studies sort of that have looked at Moderna have kind of lumped Moderna and Pfizer together. We don't yet have much data for the other vaccines other than that AstraZeneca vaccine has about 73% real world effectiveness in the UK. So how do these vaccines compare specifically for safety and reactogenicity in women? So by reactogenicity, what I mean is the side effects that occur shortly after getting the vaccine. So within the first 24 to 48 hours, and they include the symptoms listed here, pain at the injection site, fatigue, headache, muscle aches, chills, and fever. And so these are data from the CDC's V-Safe program, where vaccine recipients can register and report symptoms. And so of all the participants in this V-Safe program, over 35,000 identified themselves as being pregnant, and 19,000 received the Pfizer, and over 14,000 received Moderna. So we have a pretty robust data set to draw on. And what you can see is that if we look at the Pfizer vaccine, that the, and this separates both pregnant and non-pregnant women. If we look at the Pfizer vaccine, as you look at the first dose compared to the second dose, these reactogenic side effects are more common after the second dose. There's really not any strong trends in terms of frequency of effects according to pregnancy status. The Moderna vaccine, same thing, more reactogenic side effects after the second dose compared to the first dose. And if you compare the second dose of Pfizer to the second dose of Moderna, you can see that there's probably slightly more of these reactogenic effects after the second dose with Moderna. Fortunately, these are all usually self-limiting symptoms that resolve about 24 to 48 hours after they appear. There are also data on pregnancy outcomes from this same vSafe database, which also contained within it a pregnancy registry. And almost 4,000 pregnant women took part in the pregnancy registry. Of those, though, only 827 have completed their pregnancy. And from this publication, or this table in this publication, it shows you the frequency of pregnancy adverse outcomes, such as pregnancy loss due to a spontaneous abortion or stillbirth, and neonatal adverse outcomes, such as preterm birth, small gestational age, congenital abnormalities, and neonatal death. And what you can see is that the frequency here, showing it as percentage in the brackets, is similar to what the expected frequency is just in the general population pre-COVID. There have been no neonatal deaths associated with COVID vaccine so far. So unfortunately, there is also a very serious adverse effect called thrombosis with thrombocytopenia syndrome, or TTS, occurring after or vaccinations with 2 of the COVID vaccines. And these vaccines are the AstraZeneca and the Janssen or Johnson & Johnson vaccine. So both of these vaccines have in common the adenovirus delivery platform. AstraZeneca uses a chimpanzee adenovirus, and Janssen uses a defective human adenovirus. AstraZeneca, as I mentioned, has been authorized for use in Europe, so we only have data from Europe. The Janssen has only been authorized in the US, so we only have data from the US. And out of 25 million doses given in Europe, there have been the rate has been 10 cases per million doses. And out of 7.9 million doses of the Janssen vaccine in the US, the rate has been 20 cases per million doses. The average age is in the mid-30s with a bit of a range, although it skews very much to the younger age. What is very interesting is that there is a very striking higher risk in women. So for the AstraZeneca vaccine, the ratio of TTS in women to men is 2.5 to 1. And for the Janssen vaccine, the ratio is 15 to 0. So all cases in the US have been reported in women. Unfortunately, there is a significant mortality rate with this syndrome on the order of 20% for both vaccines. The mechanism is believed to be autoimmune. And for reasons we don't fully understand, the vaccine is inducing a cross-reactive immunity that causes platelets to aggregate and cause blood clots. And that's what leads to this syndrome. Fortunately, there have been no cases reported in the United States of this syndrome occurring after either the Pfizer or the Moderna vaccine administration. And so recently, the data on this were reviewed by the American Committee on Immunization Practices, the ACIP, and they looked at it through a risk-benefit analysis. And so what they estimated is that for every 1 million doses of the vaccine given in the US with the current US risk for SARS-CoV-2, that for every million doses, they would expect about 13 cases of TTS in younger women, 18 to 49. But the benefits of the vaccine, that's the downside of the vaccine. The benefits of the vaccine would be that it would prevent 12 deaths in this age group of women. It would prevent 127 ICU admissions and would prevent 657 hospitalizations. For older women, 50 and older, the risk of TTS would be less. There would be expected 2 cases for every million. And the vaccine would provide benefits of preventing 593 deaths, 1,292 ICU admissions, and over 4,700 hospitalizations. So based on this risk-benefit analysis, the ACIP has reaffirmed its initial recommendation for emergency use authorization of the Janssen vaccine for all people 18 years and older, with the proviso that vaccine recipients should be informed that there is this rare TTS syndrome and that it can have some very serious consequences. Particularly, it is of risk for younger women aged 18 to 49. So with that, I will end with a summary. So what we've seen is that COVID vaccines that use the spike protein of SARS-CoV-2 as a target have very high short-term efficacy and effectiveness for preventing symptomatic SARS-CoV-2. The durability of this protection, we don't know yet. And we do have some data to suggest that they still protect at very good levels against some of the variants of SARS-CoV-2 that have emerged. We don't know how well these vaccines prevent transmission. We expect that they will do a good job of that, but we just haven't had the data come out yet. The reactogenic side effects are very common, but fortunately are short-lived. And TTS is this very serious, but fortunately rare side effect specifically of the adeno-based COVID vaccines. And I think more research is needed to better understand the mechanisms of how this occurs, and in particular, the reasons for the disproportionate occurrence of this syndrome in women who receive the adenovirus vaccines. And I will stop there and
Thank you. There are quite a few questions for both of you. So I'm going to start with Dr. Henao-Martinez and ask you, and thank you both, by the way, for great talks. Let me not rush through and not mention that because they were great. Are there any diseases that are commonly misdiagnosed in travelers?
Yeah, definitely. You know, whenever you acquire like a tropical infection, oftentimes when you come back home, patients and doctors are not going to be very familiar with them. Just to give you an example, leishmania is a parasitic infection that can cause a skin ulcer, another manifestation, and sometimes that gets misdiagnosed and a lot of people get delayed. So it's always important to keep in mind an infectious disease specialist and somebody that trains in tropical diseases that are more familiar with those relatively uncommon infections here in the US.
When do you think that there will be a vaccine for children under the age of 16 available?
yeah, so I think first it will come as a vaccine for children between the ages of 12 and 16. And I expect that we'll see data on that later this summer. And so perhaps by the end of the summer, before the start of the school year, we could see that. I think the vaccine manufacturers, together with the FDA, will likely not conduct the clinical trials in younger children until they evaluate the 12 to 16-year-olds.
Andres, why did Zika suddenly go away? Or it seemed like it was very frightening and very prevalent and then didn't appear to recur.
Yeah, the main reason is, the population start to acquire some immunity. So you get some herd immunity, some protection. So you're not gonna see so much circulating virus anymore. And that's probably the main cause of not us seeing much Zika anymore.
When do you expect Novavax to come on the market for the public?
Yeah.
Questions here.
Yeah. So Novavax, as I showed, is still conducting its phase 3 trial. It has crossed over. All of the participants who got placebo have now are now receiving actual vaccines. So the placebo-controlled part of their trial is over. So I'm sure that they are very busily analyzing their data. But I've been told that, or have heard that the FDA also wants them to work on their protein assays so one of the problems with protein-based vaccines is that producing the protein in the laboratory can be tricky. And so they have to be able to show that there is very little batch-to-batch variation in the quality and the quantity of the protein that they produce. And so I think the FDA wants them to do additional testing and work out their testing a little more before they start mass producing the vaccine for general use. So I would expect probably mid to late summer.
Okay. Andres, an eager person eager to travel asks, as we all are, I am traveling to Argentina in December for a cruise. Should I have a COVID booster? Which I don't think they're offering boosters. You can both respond to this, since my shot was done in late January of this year.
Yeah, I don't think we have an official recommendation for booster. I don't know if Dr. Campbell might have more on that, but it sounds like it might be a recommendation in the future after a year. So I think if the travel is within a year, the full schedule for the COVID should offer enough protection for traveling.
Yeah, so what I would add is that we do know from some published data that antibody levels remain high for at least 6 months after vaccination with the RNA vaccines. And so I don't think there would be a need for a booster this soon. I think that it is very likely that boosters will be needed. There are trials going on to assess that. And I think it's very likely that if we do end up getting boosters, that they will be with boosters that are targeted to the variant strains. And so we don't have boosters available yet, but I do expect probably before the end of the year.
How do you test a patient who may have, how do you test if a patient who has a suppressed immune system has responded to the mRNA vaccine? If somebody has a suppressed.
So
the
clinical trials that have come out, or the clinical trials that I've reviewed, all excluded people with significant immunosuppression. They allowed individuals with well-controlled HIV, but they didn't allow individuals who were getting chemotherapy for cancer or had organ transplants, et cetera. So we don't know how well these vaccines work in these individuals. There are some data that the antibody levels that are produced, particularly like in solid organ transplants, so this would be people with kidney, heart transplants, the antibody levels are less, but antibody levels aren't the whole thing. And what's important is the protection from actual infection. We don't have that data yet for immunosuppressed people.
This is on a non-infectious component of travel, but what are the current high altitude sickness prevention medicines?
Yeah, we talk about, there is especially a medication called Diamox, acetazolamide, that can be given as a prophylaxis to prevent the high altitude sickness. We also, in very athletes or very professional people, we also prescribe sometimes dexamethasone to prevent, pulmonary edema in extreme circumstances.
Either of you can probably answer, what is thrombosis?
Well, since I put it up on the slide, sorry, I should have explained that. So thrombosis is just the medical term for blood clotting. And thrombocytopenia, the other part of that, is the medical term for low platelet counts, which are a type of blood cell.
Can you talk about any particular concerns that may arise due to the use of DNA in the adenovirus vaccines?
So, one thing that has been, I've heard about, people raise concerns about is whether the DNA will be integrated and become part of our genome, and that that does not happen. The DNA does not integrate into our chromosomes, and it does not persist. It's transient and is eventually degraded by our cells. So I don't think there's any specific concerns about DNA versus RNA in terms of delivering the information for the spike protein.
For those with TTS, do they know if there was a recent or past adenovirus infection within the past year?
Yeah, that's a good question, and I've not seen data on that.
Another question is a question of infertility in teens with COVID vaccines.
So there's no evidence that COVID vaccines cause infertility. In the clinical trials enrolled women who were not pregnant. So women were tested to see if they were pregnant at the time of enrolling. However, women were advised to follow contraception measures, but nevertheless, pregnancies did occur. And the rate of pregnancies was identical in the placebo and in the vaccine arms in these placebo-controlled trials. So absolutely no evidence that there's an effect on fertility.
Can individuals on biologic agents receive COVID vaccines? Is there anyone they can or cannot receive in particular?
Yes, they should receive COVID vaccines, as should immunosuppressed individuals. We know that the vaccines are safe in these individuals, but we don't know yet, as I mentioned, how well they work.
Here's a question I've heard from lots of people. If you had no reaction to the first or second virus or vaccine, is it still effective?
I've not seen any data correlating reactogenic side effects with efficacy of the vaccine. We do know that the reactogenic side effects are less common in older individuals, but we know that the vaccines work just as well in older individuals. So I think, based on that, I'd have to say that I would still expect the vaccine to work, even if there are no reactogenic effects.
There was also a question about the origins of COVID. I know a team traveled to Wuhan to look for the origins. I don't know that that was clarified. Do you have further insight?
Well, what we do know is that that it arose from a bat coronavirus. That is crystal clear from the genetic sequence information. What we also know is that it's not an engineered virus. So this was not a virus that someone took from bats and then engineered to make it worse for humans, like for a biowarfare. And we could tell that from the genetic sequence. It is possible that it could have arisen in a laboratory. I don't think there's any way to exclude that possibility. And in reference to the visit by the WHO to Wuhan to kind of explore that latter possibility, I'm actually not aware of what findings they had.
Is there any way to predict with an allergy test whether somebody is likely to have a vaccine reaction?
So there are the RNA vaccines. In addition to containing RNA, they do contain some lipid substances, and one is called PEG, And so, for instance, if you have an allergy to PEG, you should not get the RNA vaccines. And if you have an allergic reaction to the first RNA vaccine, you probably shouldn't get the second RNA vaccine. But there's no cross-allergy reaction to an adenovirus vaccine, so it leaves open those possibilities. Or once there's a protein vaccine, a protein vaccine.
In order for hand washing to be effective, how long should I keep washing? And this applies to traveling, it applies to being at home. Is water only better than nothing in the event that soap is not available? Lastly, are all soaps pretty much the same?
I'll let Andres take that one.
I was hearing that norovirus has made a recurrence, so timely question.
Yeah, you should wash, your hands with soap and water. And normally the recommendations for COVID is to wash it enough, for about a minute or so. Obviously, you need more intense cleaning. It requires, longer duration of the washing. If you don't have anything else available, I think water is probably better than nothing. It can probably rinse some of the spores and some of the bacteria. It's not going to be as effective, of course. And there are different types of soaps and the concentration of detergent. And so there is different application for different soaps, but normally for the purposes of, cleaning your hands for hygiene, any soap will do the work.
As we also heard from Dr. Barron talking about, diseases that can be communicated because you don't wash your hands, still true. So last point, I think a lot of the questions relate to questions about the safety of the vaccines. And what I've heard from you is that there's a lot of safety. I mean, they're very safe, but I think, people are nervous. This is, people want to know when is the experimental label going to be, finalized into approved, and are there causes for concern?
Yeah, so an important point is that there are no approved vaccines. So none of these vaccines are approved. There's only emergency use authorization. And what that means is that since we're in an emergent situation with a very bad and potentially lethal pandemic, the FDA has authorized the emergency use of 3 vaccines now in the U.S. Normally, the FDA waits a longer period of time, 2 years roughly, for all the clinical trial data to come in. But because of the extreme nature of the pandemic and the real risk of death or other non-deaths but bad outcomes from COVID-19, these vaccines have been put into use. Now, what's important is that in the clinical trial, so the Moderna clinical trial, for instance, enrolled 30,000 people. The Pfizer clinical trial in the US enrolled 40,000 people. Those clinical trials can detect common and somewhat uncommon side effects, but they're not going to be able to detect very rare side effects just because the population that's enrolled is on the order of 15,000 got the vaccine, 15,000 got placebo. So if it's something that occurs 1 in a million, it's probably not going to be detected in that clinical trial setting. So what's important is the continuing safety monitoring of these vaccines as they've been put into use. And that's what the CDC VSafe program does. And the CDC Vaccine Adverse Reaction System database collects this information. And so now there are data on millions of people that have gotten the vaccine in the US. And that system works because that's how these TTS effects syndrome was detected in Europe and here in the US with the was through that continued safety monitoring. So yes, there are these rare side effects that are potentially lethal, but as I showed you in that risk-benefit analysis, even with those rare side effects, the benefits of the vaccine still outweigh the risk. And as I mentioned, the variant viruses that now represent 80% of the new infections in the United States, they are much more easily transmitted. And the vaccines work well particularly against the B117. And so if you haven't been vaccinated, you're going to be at much greater risk with this current wave than you were before, just because of the increased infectiousness of the virus. And they're just as lethal. There's no change in mortality.
Well, thank you. Excellent. Lots and lots of questions, lots of people concerned. And it's so wonderful to have the opportunity to talk to both of you with your tremendous expertise. So thank you both very much. This has been a great session, and I want to thank you, and I want to thank our audience for attending. Please complete your surveys. And Women's Health Week is May 9th through 15th, 2021. Please check our center website for more information, and look out for registration information for our next talk in the fall about autoimmune diseases. And so we're so proud and happy to be able to bring these experts to you, and it's really a wonderful opportunity. So have a good night, and thank you very much.
Thank you.
Bye-bye.
Bye.